Welcome everybody to the next installation of our webinar series on the COVID-19 pandemic. I'm Joe Walther. I want to thank my co-organizer, Ambuj Singh, and we have some fantastic speakers for you today. Let me just share our orientation with you for just a second. As usual, I'd like to remind people to find out more about our series, past speakers and upcoming speakers. This is the URL for our homepage at citsucsb.edu, spring 2020. On this site, you can also sign up for our mailing list where we send announcements of forthcoming speakers. We ask for your feedback to a survey we have put online if you haven't seen that yet. And this is also where we link to the videos on YouTube from the recordings of previous presentations and slides for those presenters who have sent them to us before. Today, we will have two speakers. As a departure from our usual routine, we will have Dr. Vando Reynoso speak first, and then we'll have some questions and answers. Dr. Do Reynoso has to leave for other obligations today, and then we'll have Dr. Melissa Smith, and we'll have hopefully some time for Q&A after that. If you have a question for either of our speakers, please submit it to the Q&A box at the bottom of your Zoom screen. I'll try to make the introduction short because I want to hear our speakers as much as you do. Dr. Vando Reynoso is the Director of Public Health for Santa Barbara County, and she has remarkable qualifications, a lot of experience in California and elsewhere in public health issues, and she'll be talking to us today about the COVID-19 pandemic in Santa Barbara County and efforts by the health department and other partners to safeguard community health. We'll take a short Q&A after her presentation, and then we'll go on to Dr. Melissa Smith, a family medicine physician, a UCSB faculty member, and part of a University of California-wide project on health equity systems. Dr. Smith has been involved for a long time in public outreach for medical and health information. She'll be talking to us today about cross-sectoral collaborative efforts in recently formed Latinx and Indigenous migrant COVID-19 response task force. We're looking forward to hearing about those efforts as well. So I will get my screen out of the way and turn it over to Dr. Vando Reynoso. Thanks for joining us.
Thank you for having me today. So I'd like to start my presentation with just a brief background about the context of our local response. So beginning March 12th, Santa Barbara County declared a local health emergency in response to the COVID-19 pandemic. On March 19th, the stay-at-home order was issued. So for April, we were in the thick of responding to the spread of disease in our county. And it was not till the beginning of May 4th, given data, we were allowed to, as a state, beginning to open with lower risk businesses, and our community attest that we had the capacity, our numbers were stable, and we had the capacity to address any surge. And through our variance attestation, we were allowed to open quicker than many of the counties around us. And so at the end of May, we saw the beginning of higher risk sectors being reopened. Primarily, when we talk about higher risk sectors, we're referencing the hair salons and the faith-based convenings. And we anticipate that because our numbers are still stable, we have fluctuations, but the numbers are stable. Our hospitalizations and our healthcare infrastructure and our testing, all of that is stable. And so we anticipate supporting the reopening of additional higher risk sectors this Friday. So want to ground us in the cases in Santa Barbara County. So we start tracking really beginning of April, even though March 15th we had our first case. Where we are at now, as of yesterday, we have so you see the blue line, we grew, and this bump right here was the outbreak in our local federal correction institution, the Lompoc prison system. And so as of yesterday, we have 1,817 total cases. Of that, we have 1,621 fully recovered, and with 181 active cases. So this, in context, this is 10% of our total cases are active. As of yesterday, we had 48 cases hospitalized, and 9 new cases recorded as of yesterday. So one of the things that we have started doing is tracking our race and ethnicity in our cases. So this data shows you that as of May 8th, we've captured the number of cases, and we're able to categorize them according to the race and ethnicity data. So of the 443 cases, we've excluded 145 because of the missing race and ethnicity data. So this is an interesting pause for me to share that many of our cases initially even were very reluctant to share or disclose race and ethnicity data. And as we moved into disease mitigation, we were not doing contact tracing for many of our cases. We're really focused in April, mid-March and April, on doing contact tracing for our congregate settings. And so how we were able to gather the race and ethnicity data, we implemented a retrospective survey tool where our epidemiologist team would go and interview all the cases. So as of May 8th, we were able to connect with 443 cases. So here, as you can see, local data indicates that we have a disproportionate impact on various communities. So for instance, for the 298 confirmed cases where race and ethnicity have been identified and compared with the California Department of Finance County, we have roughly 81% of our cases being Latino, Hispanic, despite comprising 47.9% of our county's population. And we have 26.5 are non-Hispanic white, despite comprising of about 43% of the county's population. So as I mentioned earlier, we saw a huge steep in our curve due to the outbreak at the Lompoc Federal Corrections Facility. And you can see, as you can see here, that unfortunately of our 597 cases, 93% we were missing the race and ethnicity data. But even so, of the 42 cases with information available, Latinos and Hispanic comprise the highest percentage of cases at 4.5%. And so we have initiated a request to the prison system to get this missing 93% data. community hospitalization. So as of May 8th, a total of 89 COVID patients have been hospitalized in the 5 hospitals across Santa Barbara County. Uh, data on race and ethnicity were available for 79 of these patients. So that's roughly 89%. So over half were Latino Hispanic, so roughly about 56%. As a point of comparison, in 2018, 38% of all hospitalized residents of Santa Barbara County were Latino and Hispanic. This is, in comparison, we were able to do some data compiling for the number of inmates that were hospitalized. So of the 26 inmates that were hospitalized as of May 8th, 50% were unable to be interviewed to gather race and ethnicity information by the time of publication of this report. But even so, of the cases that we were able to see, we see a disproportionate representation in the Latino and Hispanic population as well. So what is the role of the local public health department? Our response has been centered around testing. Early in the response effort, given the shortage of testing supplies, we quickly partnered up with our community stakeholders in the healthcare system and work with our partners to create a prioritization list of who should be tested. And this was done well before CDPH and other entities were thinking about it. So our response was, here in Santa Barbara County, we had limited supplies, so we needed to be thoughtful and intentional about identifying who to prioritize in our testing. And we continue with our role in testing in making sure that sufficient testing supplies and sufficient testing availability throughout our community. Safeguarding the healthcare system. From the beginning, we were worried, as many other communities, about overburdening our hospitals system. So we partnered up with our county departments to stand up alternate care sites and to alternate congregate care sites. We additionally also advocated on behalf of our healthcare system for scarce medical supplies. And not only did we advocate for the scarcity, the supplies to meet that scarcity, we also devised a very methodical, very intentional algorithm to allocate the needed supplies. Protecting the vulnerable population is one of our values in public health. So in a pandemic, quickly we identified the homeless population, the elderly population, especially homeless and seniors and with comorbidities. We also identified farm working communities, as in particular those who are bilingual or monolingual, as perhaps having barriers to testing. And the other is one of our core function is to contain the spread of disease, and we do that through contact tracing and then isolation and quarantine. So our isolation and quarantine I'll speak to a little bit more, but that is an effort born out of the necessity to protect our vulnerable population as well as the general population from the spread of disease. The other function that we have been doing is creating a health education system so that everyone in our community in real time could get the health education, the health information needed to stay healthy, to prevent disease. And we did the health education really mindful of making sure that it was bicultural, bilingual, and culturally appropriate. So we put a lot of thought into everything that we were posting on our social media or developing in our PSA and in our press conferences. Speaking of which in the middle of the crisis response, we quickly realized the necessity to manage the information because, as you know, in the absence of information, there's a lot of misinformation. And so there were a lot of fears and a lot of anxiety and a lot of worries. So we also partnered up with our emergency operations center to make sure that our public information officer and we had a team of health educators really crafting messages to be shared at our daily press conferences, as well as in our press briefings and press releases. Another cornerstone of what we have been doing is capturing the data and being able to use the data to parlay that into the metrics that the state needed to allow us to open, and to also making sure that we were keeping an eye on the pattern of disease, the trend in disease at the local level, so we could tighten up or loosen up as the state reopened. Um, you know, we in our response, we could have not done everything that we needed to do without our partners throughout the healthcare system, throughout the community, throughout the nonprofits, throughout the governmental entities. So this has been an amazing response effort because of all the partners that we have in our community. And we did all of this really being mindful of health equity and looking at our response effort through the health equity lens, making sure that as we respond, we were thoughtful at asking ourselves and encouraging our partners to be mindful of, are we looking at this? Are we being sensitive to all the diverse needs in our community? And how can we do better in terms of responding in real time? So earlier I talked about one of our mission or our goals, first and foremost, was to protect the vulnerable population. So we stood up an isolation and quarantine unit. And this just shows you the effort in what roughly 22 days we had in our isolation and quarantine effort. So that's hand in hand with discharges from the hospital, or referrals from a private provider, or referral from a homeless shelter, or law enforcement. So we have a transportation unit that would go and pick up the client that needs to be quarantined. And so we offer quarantine, isolation, and quarantine to anyone who may have an infection while they wait for the test, or while they wait for the results, or simply were in direct contact with a case. And so these are individuals who don't have access to isolation and quarantine period, the rough 14 days. So while they are in quarantine, we offer 24/7 basic support and medical support as well. So that could mean shopping for basic necessities, bringing food, bringing various medical supplies as well. And we have nurse case managers 24/7 as well to support should there be a health crisis. I mentioned earlier that by Friday, we anticipate opening additional 12 sectors that the governor shared last Friday. But how we do that is in partnership with the state. And so the state monitors our data. And if our data is, if we don't meet the threshold, or if we exceed the threshold, there's targeted engagement with our department about resources, processes that are needed so that we can meet the metrics. So on the public-facing website at CDPH, they list the metrics that all counties are held accountable. So that's elevated disease transmission, increasing hospitalization, and limited hospital capacity. And I won't bore you with all the methodology that went into developing these metrics. But happy to say that Santa Barbara received a green check in all of the categories. One of the things that the Public Health Department, we worry about not only what's happening in our community in terms of the disease transmission and hospitalization and our capacity for surges, but we also worry about the landscape in San Luis Obispo and Ventura. So we monitor not only our county, but the other two nearby counties as well. And available local data. So what you've seen briefly here today are contained in the two reports that are soon to be published. The countywide race and ethnicity report is still in draft form. I'm hoping to release it either later this week or early next week, and a study of Santa Maria. So this is the reason why we picked Santa Maria is that as you can see from this just brief sketch of data, our overlying case is, if we disregard the black line, which is the prison numbers, the disproportionate number of our case is stemming from Santa Maria. And so this just describes the new cases in Santa Maria for the past 2 weeks. So we worry about the occurrence of the cases in Santa Maria. So we delve deeply into our cases, and we'll be able to report out the profile of our cases so that we can engage not only policymakers, but community stakeholders and community members on how to stem the tide and improve our numbers. So with that, I want to say thank you for inviting me to briefly share our local public health department's experience in managing the COVID-19 response in Santa Barbara County. I have to step out at 1:30, but meanwhile, I am available for questions. And if I don't get to your questions, you have my contact information, and I'm more than happy to communicate with you through email.
Thank you so much. So we have time for a few questions before Van has to leave. So we have 3 questions that have been posted. So let me start with one of them. So the first, how long does it take for the data collected to be made public? What entity releases the data? Is it state, county? So what is this process by which data collection to data release, if you can tell us about that?
Okay, so how long does it take for the data to be collected, to be publicly available? So if you visit our website, publichealthsbc.org, there is a tab called Reopening Metrics. You can download anything that we have on that immediately. So Monday through Friday, we update our data by 5 o'clock. The other thing is we are working to align ourselves with how the CDPH is releasing their data. So they lag, I believe they've been trying to get better, but I believe they still lag a day or two, if not sooner. So we will soon be listing the data and the race and ethnicity data as well in real time. So that's on a daily basis. We're still working out the kinks and making sure that our methodology of sharing that information is correct before we go live. But for now, everything that is regarding case numbers, case status, where the cases are, our hospital capacity or testing capacity, and all the other metrics is available on that website.
Thank you.
And-
Let's move to the next question. How does the public health department implement contact tracing? How do you make it work?
So how do we make, is a very complex, but that is one of our largest unit. We have 63 or 65 people trained. And once we get a positive case, we contact the positive case and we interview for using a standardized contact tracing tool. And we go down the line list of all the exposed contacts and we go from there. We issue a health officer order to quarantine the positive case, and we ask their direct contacts to self-isolate, and we monitor the index case as well as the contact cases for the exposed cases for possible disease.
Thank you. One more question. What is the reason for Santa Maria having a larger number of cases?
So that is the $1 million question. When you look at the data, it appears that many of the cluster cases happen in high density living areas. So I know from other published reports in other jurisdictions that high density living situations can suggest a higher number of transmission. That we also interviewed our cases for health insurance status, for access to healthcare system, for places of work, for knowledge of COVID-19, knowledge and capacity for social distancing, for hand washing, and all of that. And although the knowledge is high, the capacity is high, there are professions and there are socioeconomic factors that would suggest that high density living, certain professions and certain income level make it a little bit more difficult for our community members in terms of staying safe or in terms of protecting ourselves.
Thank you. There are two more questions. Hopefully we can get to those. Can you talk about the risk of transmission in indoor or outdoor activities? Are the protocols different in terms of how should we minimize transmission?
Yes, so there is from literature, we know that indoor with low ventilation and close proximity have a higher transmittability than outdoors activities with social distancing and well ventilation. So I think that broadly from a 30,000 foot level, that is the risk. And yes, we do have protocols for indoor and outdoor activities. On our website links, I want to invite you to visit our website, and through our community guidance for the sectors, we spell out very clearly how to protect the public encounters, the workers from transmission to minimize transmission.
Thank you. And then the last question, which you might not have time for, will you be helping UCSB to reopen? You can leave at any point.
So yes, so we are in communication with, actually yesterday, we were on a joint call with numerous leaders at UCSB in talking about how do we create a safe environment at UCSB for the staff and for the students. And what does testing look like, what does contact tracing look like, what does isolation and quarantining look like. So that is in discussion. And with that, I have to step into my budget hearings. So
Thank you
please,
so much. Thank you so much for your time.
thank you. All right. Please send me an email if I may provide additional information.
Thank you.
Thanks. Bye.
And let's move on to our next speaker. Melissa, please. Thank you.
Thanks so much. So I'm going to share my screen and really appreciate the opportunity to share this update with everyone about the Latinx, Indigenous, and Migrant COVID-19 Response Task Force. Are you seeing the screen? Making sure everything is good. Anyway, so it's really lovely to be able to share this. This has been a wonderful collaboration with Dr. Do Reynoso and others, and I'm glad to be able to give this update. The task force is really an extension of the work that I've been doing already at UC Santa Barbara as Director of Health Equity Initiatives, really focused on strengthening collaboration in community-based efforts on health and social justice, both with local and global partners, as well as across the UC system, because I also work with the UC Global Health Institute. But to complement this work, I also have the privilege of having a part-time position with the health department in their clinic in Santa Maria, and I work as a family medicine physician, taking care of patients, most of whom are farm workers. And most of them come from indigenous communities in Oaxaca. So for me, this is a particularly meaningful role that I have because I have spent extended periods of time in Oaxaca for the past decade, working with community-based organizations who are training leaders on sexual and reproductive health rights, particularly for women in indigenous and Afro-Mexican communities. So being able to loop back here in Santa Barbara is quite amazing. I shared an update about the task force efforts 3 weeks ago at the Multicultural Center of UC Santa Barbara. And since then, a second public health crisis has emerged as a focal point of protests and demands for change both here and around the world. Racism is an ongoing public health crisis that has been brought into sharp relief by recent events. So we know that the disproportionate impact of COVID-19, the pandemic, on communities of color is one clear instance of the relationship between institutionalized racism and community health. We've also seen that racial hierarchies and anti-Black racism in particular underlie the brutal police violence that's been inflicted on Black communities throughout our nation. And I will say that I just participated in the webinar that's featured up on the top left of the American Public Health Association. It was quite inspiring. There were over 7,000 people calling in from communities around the country from many different disciplines, wanting to take action and understand this and work collaboratively for efforts. So it was really exciting to be part of that just before joining you all. So since we've founded the task force in the end of March, our steering committee has held very important and at times difficult dialogues with members of our community who are working with the NAACP, with Black Lives Matter, the Pan-Asian Network, and La Casa de la Raza about the importance of addressing anti-Black and anti-Asian racism. And their advocacy and activism has helped contribute to some important developments. Our task force leadership made a public statement last week in solidarity with these organizing efforts with specific commitments. We renamed the task force to more accurately describe our mission, the Latinx and Indigenous Migrant COVID-19 Response Task Force. This was in response to a critique which we affirmed that the term immigrant cannot be synonymous with Latinx, given the great diversity of the Santa Barbara immigrant community. We also affirmed that this sharpened mission will include efforts to address the conditions of Black Latinx immigrants in our county, as well as gaps in services for Spanish-speaking Black people. The task force leadership also made a commitment to work with other community partners to build an inclusive county-wide health equity initiative in collaboration with the health department, centering the voice and leadership of Black, API, LGBTQ, and others, in addition to the Latinx and immigrant Indigenous communities. Our task force supports collaborative efforts to understand and address institutional racism and to work for equity in all social determinants of health in our communities, including violence against Black peoples and communities. So the origins of the task force began in a 2-year collaboration in a course focused on community-based participatory research on health inequities that I've been co-teaching with 2 colleagues from the Department of Counseling, Clinical, and School Psychology at the Gewurz School of Education, Dr. Melissa Morgan and Dr. Miriam Kia Keating. Our approach to research and to this class is based on social justice principles, whereby we seek to involve people who are directly impacted by the structural health inequities in all stages of research and action. So over the course of 2 years, we have had a number of different community partners working with us and our graduate students and undergraduates from different disciplines across the university. And they include the Mixteco Community Organizing Project, which is called MyCop, Just Communities, the Health Department, and El Centro. And what they have done is in every time of holding the course, they develop team projects that are identified as a priority by the community-based organization. All of these have been focused on the health concerns of Indigenous as well as Latinx immigrants in our county. So this winter, as the course was ending, the pandemic was emerging, and Dr. De Reynoso and I both agreed that it would be very important to pivot this class project and focus on the concerns of the Latinx, Indigenous, and undocumented migrants in our county as they were dealing with the challenges of the COVID-19 pandemic. So you saw some of the data about communities and race and ethnicity whereby people are disproportionately impacted. And this is another reflection, not only about who's impacted, but areas that are disproportionately impacted in our very own county, to the order of magnitudes of hundreds, I should say. So as you see here, this is data from yesterday that the city of Lompoc, the federal prison in Lompoc has 981 cases. The city of Santa Maria has 409 cases. The city of Lompoc has 105 cases. And that can be compared, for example, to the community of Isla Vista, which only has 1 case. So tremendous regional diversity. And I think this is really important because this reminds us that where we live, learn, work, and play affects our health significantly. And so things like access to quality housing, as Vaughn was referring to recently, that many people living in one small apartment, for example, quality education, access to healthy food, good jobs, well-paying jobs, clean air, all of these are critical social determinants of health, which are influenced by long-standing upstream institutional policies and practices that reflect axes of social inequities, including race and ethnicity, class, immigration status, gender, sexual orientation, and certainly, as we've seen throughout this pandemic and with what's going on with police violence, institutional racism being a driving force for health inequities. So the work of the task force is grounded in principles of equity, whereby we seek to center the voice and leadership of communities who are directly and disproportionately impacted by health inequities. Our steering committee includes colleagues who are affiliated with the health department, with MyCop, CAUSE, El Centro, and yours truly representing UC Santa Barbara. And since we launched this task force the end of March, we now have over 140 individual participants who are involved in the efforts. There are over 60 participating organizations from diverse backgrounds and representing groups all over Santa Barbara County, including community-based organizations, health service providers, elected officials, and funders. And we have a wonderful Zoom meeting call every Friday morning. We have since the end of March, where all of the people that I mentioned are gathered in a dialogue with Dr. Do Reynoso in this really inspiring iterative process and a rapid response cycle where community-based organizations identify the concerns that are being raised by people in their communities, the people they're serving. We collectively identify community assets as well as resources that can be shared among the task force. And then we plan action steps together. So some of the work that we've been able to do together includes doing weekly updates of the priority action areas and concerns that are being identified, as I mentioned, and those are outlined in the six areas that you see on the slide. We've had a very strong language justice focus to our work, so all of our meetings have Spanish and English simultaneous interpretation. We have developed public health PSAs, flyers, and videos in Spanish as well as in multiple indigenous languages. And this has been a great collaboration that actually took place the very first week that we started the task force. We started rolling out these videos in collaboration with MyCop, with Herencia Indígena, and with CAUSE, working closely with the health department public information officer to give the right messaging and get the messages out. We were able to very quickly implement a policy change so that no one had to pay for any COVID-19 care. This includes people who have no health insurance or who are undocumented, and we were able to get that message out through multiple networks through our collaborative. We've been organizing and community mobilizing throughout the county to get people face coverings and to coordinate the testing and contact tracing that was described by Dr. Do Reynoso, and also providing access to people who have needed supported isolation. Thus far, we have formed 2 working groups, one focused on farm workers and another on mental health, and have created a really wonderful public Google Drive of community resources so that everybody can have access to all of the information and resources that have been shared. And that's something that you can see in this link and something that we can share if you're interested. And most recently, because of what I described a little bit earlier in my talk, we have now been involved in supporting efforts focused on anti-Black and anti-Asian racism, as well as beginning this process of creating a county-wide health equity collaborative effort that we really hope is going to build a foundation for ongoing collaboration and policy changes. So one of the real delights for me has been to be involved with an incredible team of students, faculty, and staff as part of a course that we offered this spring semester to support the work of the task force. We created an independent study course, and it has been housed at the Center for Publicly Engaged Scholarship. And you see here our incredibly dynamic team of 15 people, including graduate students in sociology. There was a postdoc in English, and undergraduates from diverse fields, as well as staff from the Center of Publicly Engaged Scholarship and faculty in Chicano Studies, as well as education. And we divided up and formed 3 teams, and each team took on a different priority task. So one team was really responding to the emerging priorities that were being identified every week. So, for example, doing research that was very helpful to help address the issue of price gouging, as well as some very helpful resource finding about funding opportunities in COVID-19 that has been accessed and used by these 60 partner organizations. Another team was working on longer-term projects, including grant writing to support long-term work of the task force, as well as resources specifically to offer support for people experiencing domestic violence. And a third team was doing work around mental health and resilience and providing very helpful information to the task force around that. So all of the teams have had an intersectional justice lens to the work, and all of them have been involved in one form or another, depending on whatever issue they were working on, both demographic data analysis and helping us present the data in public forums, doing inventories of relevant resources and information, and then also helping the task force with dissemination and collaboration strategies. And finally, creating a website for a UCSB COVID-19 response health equity hub that we are very soon going to be launching. I want to just highlight a few opportunities for collaboration with the task force that are available both for students and faculty. So one is making sure that students know that there will be an option to do an independent study this summer, just as we offered this spring, and that students can be engaged with different numbers of credit hours. There are volunteer opportunities, potential internships with some of our CBO partners, and then certainly involvement. There are some students that are already involved with the mental health working group and also welcome to join the farm worker working group. And then collaborative research that can be for faculty and students. So if any of you are interested, please contact me at this email, or Alex Maldonado is a graduate student researcher in sociology who's been working with me and doing incredibly remarkable work to support not only the class, but the task force. And so I really want to give a big, big shout out to Alex for her significant contribution. And just to highlight the next steps in this broader health equity collaborative that I described at the beginning, where we really want to open it up to be as inclusive as possible, and as I said, county-wide. And we will ensure that we will have diverse representation in leadership and planning to include Black, API, LGBTQ, and other community members, as well as those who are from Latinx and Indigenous migrant communities. We will be offering training on health equity, institutionalized racism, anti-Blackness, and implicit bias. And remember that the goal is to be inclusive. That means that health service providers and elected officials and community-based organizations, that everybody would have an opportunity to participate in this kind of training. We will be definitely using a data-driven process that is looking at health outcomes and their relationship to the social determinants of health in order to guide policy changes. That's a very important approach. And that all of these, this kind of commitment to this broader collaboration also implies action steps on the part of the task force right now to focus on the concerns about disproportionate Black suffering from the pandemic, racism against API communities, and how that might limit their mobility, mental health, and physical access to COVID care. I know that there was a recent webinar at the Multicultural Center focused on that issue. So that's a resource that already exists through UCSB. And then finally, accessing COVID-19 related data from the Longpo Prism to determine how to support efforts to protect the majority Black, Latinx, Indigenous, and immigrant inmates in their safety. And you may not have gathered this from what Dr. Do Reynosa said, but the prison has total control over how the pandemic is managed. The health department does not have access to their data or to any way to actually impact how care is being provided. So that's something that will require some support from many partners in order for us to be able to get access to that data and try to have an impact there. And finally, I just want to say thank you to all of you for whatever you're doing in your own communities to contribute to the health and well-being of your communities, your families during the pandemic. I really want to acknowledge the importance of drawing on the wisdom and the expertise of organizations who are working upstream for structural change that is so critically important. And in particular, organizations like Black Lives Matter and the NAACP who are leading struggles against racism. So these efforts are so critical to achieving health for all, both now and in the future. And our task force stands in solidarity with these organizations. I invite you to check out their websites as well as the websites for Human Impact Partners and the American Public Health Association, all of whom are doing incredible work to take action on structural racism as an ongoing public health crisis. Thank you.
Thank you very much, Melissa. Both our presentations were rich with data, and I appreciated the additional narrative elements that your work has added to that. One question that may come up, in light of the really amazing work that you and others have been doing to provide health equity, overcome systematic racism, and deal with the inequities that are faced by different minority groups, we've also seen, of course, in the last week or two, a lot of other efforts directed to overcoming racism and systematic prejudice within society. And I'm speaking, of course, now about the reactions to the George Floyd murder and the overwhelming and very important public responses that we've seen, including the public rallies and public protests that have been taking place. Mm-hmm. These are really important and really high impact events that have been taking place. Yet, ironically, they seem in many cases to be working against some of the social distancing practices that have been so important to encourage to reduce the spread of the disease. I don't mean to put you in a controversial position, but I wonder if you have any observations. I myself am not aware whether social distancing has been practiced in some of the peaceful assemblies that have been taking place within our community. But of course, we see across the nation, there's been a lot of variability in that. Do you have any insights or comments on that?
Well, I do. I think that the protesting is, of course, we've gone from 0 to 60 by moving from being at home, sheltering at home, to these very large and very impactful protests. And I was just reading the LA Times this morning, and they were referring to a letter that was signed by over 1,000 professionals, including many public health professionals, who said that this was a very important thing to be doing, that offering tremendous support for the protests because of how critical it is to be addressing the issues of structural racism in our society, but also to remind people of the importance of the basic protocols that we all know now by heart. So wearing masks all the time, cleaning your hands, bringing hand sanitizers, trying whenever possible to stay 6 feet apart from people. And certainly the recommendation now is that if people did participate in any of these large protests, that it would be wise to get yourself tested, not the next day, but 5 to 7 days later, up to the incubation period is 14 days. But just to make sure, because of that increased exposure risk, that we are all conscious that we could have contracted the COVID-19 and then be passing it on potentially to others, in addition to our own health and well-being.
I have a quick follow-up on that. So it seems that it required one form of inequality to illustrate the kind of it. You had to have a response to how people responding to COVID-19 and the fact that it was not a balanced, it affected everyone in the same manner. And that helped to drive people and make people aware of different kinds. So this awareness between two different aspects, and both have come now together and have people made more aware, I think it has a chance to achieve something. What's your, you have seen these movements come and go, people becoming aware for the short term, and whether that drives long-term changes. Mm-hmm. Where do you think we are in that process right now?
Well, as I mentioned, I just got off of that American Public Health Association webinar where there were over 7,000 people calling in from all over the country, and some extremely wise leaders the former president of the American Public Health Association, Dr. Kamra Jones, was speaking very eloquently about the unique opportunity that we have in this moment. And you're right, I think the combination of seeing graphically how the pandemic is impacting disproportionately communities of color, first of all, and then that juxtaposed with horrible, brutal police violence, I think is raising a level of awareness that I think is, we've never seen that in this country and in the world. It's just very moving to see the kind of solidarity and recognition that institutional racism is affecting communities around the world, people of color, and that we need to change. And the solidarity among so many different groups to work for change has been very moving. So yes, I agree that it's an incredible opportunity. And what Dr. Kamra Jones was guarding against is, I think I'm looking at my notes from today's talk, the somnolence of racism denial. So she said, remember, that we've gone through this many times before. We have terrible, the murder, assassination of Martin Luther King, the murder of how many other Black leaders, and people go back into the status quo. So we are really calling for this kind of public reflection and thinking about how is racism operating in our daily lives, in our workplace, in our childcare center for our children, in our, just really asking us to respond to this call for action, to reflect collectively about how we can make changes that will address the root cause.
Thank you. Thank you so much, Dr. Smith. Are there any questions, any other questions from the audience? We have 1 minute or so left. Well, if not, I think I'd like to thank both of our speakers, and thank you to the audience for coming to this talk. We are going to continue for at least a few more weeks, and you have a chance to participate in a survey to drive our actions at that point. Thank you so much for joining in. Thank you. Bye.
Thank you.
Thanks, everyone. Bye-bye.